Rajiv Thavanathan. I'm one of the fourth-year residents in the FR program. And today we're going to take a deep dive into the very sexy topic of hyperglycemia in the ED. And this will be a one-man play in 3 parts, starting with recent evidence regarding management of non-emergent hyperglycemia in the eMERGE. Then we'll take a look at subtle and some atypical but really important presentations of DKA. And then hopefully try to figure out some ways to minimize problems with our DKA protocol here at TOH. Now, I do firmly believe that the most important part of a talk is the title. And I'm really proud of this one. It's called "No Thanks, I'm Sweet Enough," which is a quote from what movie? Does anyone know? No. From Snatch, that's right. It's Guy Ritchie's finest work. But I want you to know that I didn't just settle on the first title that I thought of. You know, there were some other contenders. There was DEFG, Don't Ever Forget Glucose. There's Whoa, 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 The Sweetest Thing. Sugar, Sugar, and my personal favorite, Putting the Us in Diabetes. I have to open like that because I just got to get it out of my system and then we're okay. So let's start with the case. This is something I think most of you can relate to. You're seeing a 60-year-old male in urgent care. He's got a non-productive cough and some upper respiratory tract symptoms for the past couple of days, but no real fever. But he's noticed his home sugar readings have been sort of ticking upwards every day in the high teens, around 18, 19, instead of his baseline, which is like 9 or 10. Now, this morning, his strip read as high, which means more than 33. Otherwise, he's been pretty well. Now, his past medical history is significant for type 2 diabetes, hypertension, and cholesterolemia. He's on metformin, insulin, and some other meds. He's afebrile with pretty good vitals, but his point-of-care glucose in eMERGE is still reading high. So I want you to think about what investigations you would do for this patient if you were seeing him just down the hall in urgent care. I think most of you would probably send some blood work to see what was going on and confirm the level of the glucose. So you send the blood work, and other than the glucose being 38, his lights are normal, there's no white count, there's no acidosis, he doesn't have serum or urine ketones, and the remainder of your half-assed infectious workup is normal. So, because that's what we do. Barb, I need you sitting like right at the front, because, yeah. So what would you do for this patient? Who in here would give him fluids? Who in here would give him insulin? Some people, would you give him maybe just an extra dose of PO metformin? Would you just watch him and pray that his pancreas starts squeezing out some extra insulin? And besides that, what's your endpoint with all these treatments? When's he safe to go home? Or is he safe to go home now? These are some of the questions I want you to have in the back of your mind as we go through the first third of this talk. So we all know hypoglycemia is bad. DEFG just gets hammered into us even from medical school. I've already referenced it once already. But what about hyperglycemia? And I'm not talking about DKA or HHS. Just for some context, I don't know if you guys know this, but more than 10 million Canadians are living with diabetes, making it one of the most prevalent chronic diseases that can show up in our ED. Data from the CDC in the US is expecting that diabetics are twice as likely to utilize ED services as those without the disease. And this probably doesn't come as a surprise to you, as diabetes and hyperglycemia are frequent chief complaints, representing 1% of our ED chief complaints. These numbers are expected to increase, and Diabetes Canada estimates that the prevalence in this country will increase by 44% over the decade leading up to the year 2025. Even more alarmingly, 57% of Canadians with diabetes reported they can't afford to stay on their treatments due to high out-of-pocket costs for the needed medications and supplies. The average cost is greater than 3% of the average income for these patients, or greater than $1,500 to $2,000 per year. And as always, our ED population is at higher risk than most. In a recent study, Josephson found that 36% of diabetics presenting to the ED have what would be considered very poor control. And that number is 18% in endo clinics and 18% in family med clinics. Wang et al. Described that in the last 5 years, although hypoglycemia rates have been going down, hyperglycemia in the ED has been increasing, especially among older adults. But despite numbers as concerning as this, if you're like me, or the way I used to be, I guess, it's kind of hard to get too fired up about hyperglycemia. In a 2010 multi-center survey, 3/4 of eMERGE docs claimed that they routinely refer patients with hyperglycemia, but many barriers emerged from that conversation. The most frequently cited were limited follow-up, insufficient time and resources, and feeling like it's outside our scope of practice. I want to share a quote by Ryan Radecki, who some of you probably recognize from a great online resource called EM Lit of Note. He said, "When the writers of television drama imagine the emergency department, they imagine, emergencies. Life, death, gray areas in between, and the drama of the critically ill. More and more, our emergency departments fill up with the asymptomatic, hypertension, and hyperglycemia. Silent killers, to be sure, but on geologic timescales compared to the attention span of most people in this room. Asymptomatic hypertension is nearly always an inappropriate ED referral, and now, just the same, we see the same strains of futile peddling in hyperglycemia. Although I no longer share this blasé attitude towards elevated blood glucose, the reality is that there's a paucity of evidence as to how we should manage these patients. In fact, there are no guidelines nor consensus on how to manage and discharge ED patients with non-emergent hyperglycemia. So that's without DKA or HHS, the so-called well hyperglycemic. But it behooves us to appreciate what evidence we do have to get an idea of what's working and what's not. So let's start with some looking at IV fluids. Who's given crystalloid to a patient with the chief complaints of hyperglycemia? Yeah, pretty much everyone, right? Did you actually ask yourself, were they dehydrated? Or did you ask yourself, what kind of glucose lowering you expected with the fluids? If you didn't, you're probably not alone. It's a common practice, although there's very little data actually supporting that use. The best study that I could find assessing this was from USC in Los Angeles, although it was published in CGEM. It's very, very simple. It's a small study. It's about 50 patients, 50, and they performed a non-blinded randomized control trial of adults with an ED glucose greater than 14. They randomized them either to bottled water, like what I have here, or a 2-liter bolus of IV saline, and then measured the change in glucose at 2 hours. They found that after 2 hours, the oral fluid group had a decrease of 3.4 millimoles a liter, and IV fluids had a decrease of 4. Now, there were no adverse events observed in either group, and the author's conclusion is that oral and intravenous fluids were equally efficacious in lowering blood glucose levels. Now, if I kept someone around in the department for 2 hours watching them chug a 2-liter of water for a decrease of 3 millimoles a liter, I'd argue these interventions are equally ineffective. They themselves go on to say, not these exact words, but they're like, to be honest, we didn't really have a group without an intervention, so maybe the reduction was just a function of time. But at our hospital here in LA, we have a policy that says if you're hyperglycemic, you get IV fluids. So knowing this, are we still expected to keep hitting people with IV or oral fluids in the absence of osmotic diuresis and extending their ED stay for these numbers? My takeaway is probably not. And I try to make the takeaway points really obvious. It's just red letters, bottom of the screen. And Mike Hale is going to keep track of them as we go for us, so we can check in with them every so often. No pressure, Hale. So what about insulin? Insulin makes sense, right? Who's given insulin to a patient with a chief complaint of hyperglycemia, even if they weren't already on it? How much did you decide to give? Did you use maybe the sliding scale PPO that we have in Emerge? There's a lot of studies about using insulin for glycemic control on inpatient outcomes and for hyperglycemia secondary to other pathology like MI and stroke and sepsis. But there's only one study that looked at specifically an ED population. Now, this one did include discharge and admitted patients with hyperglycemia, so it's not quite that just dischargeable, relatively asymptomatic hyperglycemia I'm trying to focus on, but I still thought this study was worth including. It's out of an academic center in Chicago and was published in the Journal of Emergency Medicine in 2011. Their thinking was, well, once they're admitted, we're supposed to keep glucose below 10, so maybe we could bring that care down to the Emerge and get things started a bit early. So they called this the Red Heat Protocol and was developed by a team of nurse practitioners, endocrinologists who specialize in diabetes management, hoping that they could get the glucose down before admission or discharge home, and they could do it to that American Diabetes Association goal of less than 180 milligrams a deciliter, which works out to be 10 millimoles. They thought maybe we can do this safely, and maybe we can do this without increasing inpatient or ED length of stay. So they call this a quasi-experimental design, comparing an intervention group to a historical control group. The inclusion criteria for the study included patients aged 18 years or older with a known history of diabetes, and they were excluded if they were pregnant or diagnosed with a more emergent diagnosis like DKA or HHS. So this is at least partly that lower acuity population that we're trying to look at. Now, their outcomes included absolute changes in blood glucose during the Emerge stay, and the hospital and Emerge length of stay, and the frequency of hypoglycemia less than 3.8. So they didn't exactly collect a ton of data, but for what they did have, the groups were similar, although about 50% were African American, so that has some implications for our generalizability here in Ottawa. And about 2/3 of these patients ended up getting admitted, which I think is a very high number. And somehow it escaped them to describe other important clinical characteristics. The two obvious ones are whether or not it was type 1 or type 2 diabetes, what kind of medications they were on, that kind of thing. And I'm putting this protocol up not to confuse you. It's obviously very complicated, but just to make the point that they weren't exactly giving small boluses of insulin. For sugars more than 20, they were giving like doses of like 20 to 25 units. Now, the results were that the absolute reduction in blood glucose was better in the intervention group. So it was about 10 units dropped instead of 5. The mean length of stay in the emerge was the same, about 4.5 hours. The hospital length of stay in the intervention group with the insulin was a little bit shorter. And the episodes of hypoglycemia were only present in the insulin group. So there was 7.4% had a sugar below 3.8. So their takeaway was that this insulin protocol worked to reduce glucose by an extra 5 millimoles. It improved hospital length of stay, and according to them, was quote-unquote safe. Well, sure, insulin lowers glucose, and I shouldn't brush aside the 36 hours less in hospital, because that could potentially be a big cost savings. But if it didn't affect admission rates, if it didn't affect ED length of stay, and despite their claims of safety, if 1 in 14 patients are getting iatrogenic symptomatic hypoglycemia, I don't know that we can extrapolate that this intervention is either necessary or safe. So Mike, what was the first one? Fluids? Okay, unless diuresing. And insulin, what do you think? Excellent. Public school education is really working for you. So maybe you're starting to buy into my brand of nihilism here about hyperglycemia. Maybe you're wondering if there's any evidence that we can defer blood work on some of these patients and just kick them out the door right away. This is just a quickie, and it's not exactly a new study. It's from 2007. It's from the European Journal of Emergency Medicine, where they looked at 510 patients at 2 university hospitals in Brooklyn with moderate hyperglycemia. So that, for them, it was defined as between 11 and 33, trying to figure out if, after some regression analysis, they could identify a group who was at low risk for their composite outcome of DKA or potassium abnormalities. That's a K greater than 5 or less than 3.5. Now, in this study, 25% were type 1 diabetics, and 45% were on insulin before enrollment. They found 1 in 5 patients had either DKA or a potassium imbalance, and after logistic regression, they found they were unable to define a subset that could safely defer this blood work. So keep in mind, only 4.8% actually had the DKA, and they didn't give any numbers about how the potassium abnormalities were treated, if at all. So the best model they could come up with had a sensitivity for bad events, the DKA or the potassium, of 76% and a specificity of 43%, which is an accuracy of about 50%, with likelihood ratios that are pretty unimpressive. So rightfully, their conclusion, after all was said and done, the investigators said that they couldn't define a subset that had moderate hyperglycemia that you could safely defer blood work and avoid DKA and or potassium imbalances. Now, obviously, this study has significant limitations. There was no randomization, so there's the possibility of selection bias favoring the entry of sicker-appearing patients. And the composite outcome, as people know from Journal Club, is a bit troublesome because it creates sort of a false equivalency between DKA and a potassium that might only be like 3.4. That said, I still think that, based on this study, that blood work is probably the smart move to do. Hey, so what were the first two things? Fluids? Insulin. And?
Blood work is pretty smart.
Props, pretty smart. Very good. So bank that in your own noggin. Now, one of the themes for today, and the big ones I want to tackle, is why even bother treating these people in the first place? Presumably, we think it's going to reduce some sort of bad short-term outcome. Hopefully, you guys aren't thinking it's doing some long-term benefit to them. And this is maybe the most important pair of articles I'll talk about today, and the question that is most relevant to our day-to-day practice. When someone has this moderate to severe hyperglycemia without DKA or HHS, what should be our target glucose level before discharge? Until recently, there's been no studies in the ED population. But you might have heard of this one because it got some attention when it was published in Annals late last year. Krish and Maggie actually presented it, I think, as one of their top 10 articles at NCCEM. And the author, Brian Driver, wanted to know, is glucose level at time of discharge from the ED associated with a 7-day ED revisit or hospitalization? So that's a pretty practical question, I think. This is a single-center, retrospective cohort study out of Minneapolis. That's home of one of my favorite bands, The Replacements, if you guys don't know. It's an urban level 1 trauma center with about 100,000 visits per year. And they looked at 566 encounters over a 2-year period, that's 2010 and 11, of patients with hyperglycemia, and they defined that as greater than 22. And this is the important part, that they were discharged home. So patients received care as determined by the treating doc. They didn't get any specific intervention. They didn't get any sort of protocolized care. And this was for patients greater than 18 that were discharged from the emerge. Now, they excluded type 1 diabetics because they developed DKA more often, and they thought that would cloud the results. So that's important to remember. They also excluded people that had a chief complaint of hypoglycemia or people that required admission to the hospital, like I said. The adverse outcomes, I think, were also very practical. It was DKA, HHS, repeat visits for hyperglycemia, or hospitalization for any reason at 7 days. Now, the abstractors weren't exactly blinded to these outcomes, but in good faith, they did do the 7-day outcomes before looking at any other variables, which is kind of just like research, like the honor system, basically. So they identified 706 encounters, and that represented 566 with hyperglycemia ending up being enrolled, and that was 422 unique patients. 12.5% were lost to follow-up, where they couldn't figure out what happened to them at the 7 or 30-day mark. Now, as you're probably expecting, the ED management, if you don't tell them what to do in a study, varies quite a bit. And this is kind of a busy table, so we're going to break it down a little bit. 73% got a basic metabolic panel. 69% got insulin, and the average amount was around 12 units. 79% got IV fluids, and it was usually about a 2-liter bolus. And it wasn't always the same group that got insulin and fluids. It was only 60% got both. And a bunch of cowboys, 12%, didn't give insulin or fluids to these patients. Just so you know, their mean arrival glucose was 27, and the discharge was just below 20. I wonder if that's not a coincidence, because that's a number that I've heard before. People seem to arbitrarily want to get a glucose below 20 before sending someone home. And these patients weren't exactly well controlled. Their A1Cs were above 10. There was no episodes of DKA at the index visit, and 2% rate of hypoglycemia while in the emerge. That's less than 3.3. So here are the important 7-day outcomes just summarized for you guys. There wasn't really many. There was return visits of hyperglycemia being 13%. Hospitalization was 7%. There was 2 patients got DKA within a week, and no one got HHS and no one died. Now, I left the iatrogenic hypoglycemia up there just so you could sort of compare the two. They did some fancy statistical analysis using something called generalized estimation equations. Please don't ask me to explain it. To adjust for confounders, and they found that elevated discharge glucose level was not associated with an increased risk of repeat ED visits or hospitalizations at 7 days. Now, there's a bunch of fancy tables saying this with confidence intervals, but you just have to trust me. All the odds ratios were basically equal to 1 right on the nose. And this continued to be the case even when they split it up as a continuous variable to be a dichotomous variable, with the threshold being 19 as the glucose level. So they sort of just said, okay, let's split them up high and low, and it was still odds ratios of basically 1 right on the nose. So it doesn't appear like there's anything special to be gained of that arbitrary level of discharging people once they're below 20. Similarly, drawing of a chemistry panel, administration, and insulin, and IV fluids were also, none of these were associated with a decreased risk of 7-day repeat ED visits and hospitalization. But Mike Hale could have told you that already. If we really want to weigh this out, this particular study, the outcome measures were pretty objective and patient-oriented. There was county-wide ambulance records that they reviewed, and if they found one, even if they went to a different hospital, they assumed it was a hyperglycemia visit. The inter-observer agreement in the study was great, and they did a worst-case scenario sensitivity analysis for lost patients as well. Now, obviously, like all studies, there's some limitations as well. You know, the abstractors weren't blinded. It was a retrospective study, and clearly the care wasn't standardized. That is to say, why some patients got certain treatments prior to discharge wasn't clear from this trial. And it's also a single center, so it's potentially not all that generalizable. And I also noticed that about half had hyperglycemia as the chief complaint. I can't help but wonder with like the kind of queuing that we get, if they get treated differently than someone where it's just incidentally discovered when you send blood work. This is the first investigation describing ED treatments and 7-day outcomes for patients with elevated blood glucose levels who weren't in DKA that went home. And their conclusion, which I think is fair based on what they have, is ED discharge glucose in patients with moderate to severe hyperglycemia was not associated with 7-day outcomes of repeat ED visits or hospitalization. Attaining a specific glucose goal before discharge in patients with hyperglycemia may be less important than traditionally thought. Now, it's very important to remember this does not apply to type 1 diabetics. And frankly, I think the smart move is to consider correcting hyperglycemia in patients being discharged with an infection because of the immunosuppressive effects of hyperglycemia. But this is the best evidence we have so far telling us the approach to asymptomatic hyperglycemia, and it should be focused on ensuring appropriate outpatient follow-up and treatment for long-term glycemic control instead of aiming for an arbitrary threshold before discharge. So that's all well and good, but don't you kind of wish we had some maybe like local data? And I can't think of a better place to start for hyperglycemia than the old Beaver Tail Shack. Not that I went there and did any research. I'm not a big Beaver Tail fan. Now, you might have seen Hans Rosenberg's EM Ottawa email from last week that Justin Yan had actually just published on this topic as well. And that was in the International Journal of Emergency Medicine. And you'll notice if you read the list of authors, it's also got the seal of approval. And so glad he's not here. He's not here, right? No, okay. So this was a one-year health records review over the calendar year 2014, and it represented 4 EDs, 2 of which were the civic and the general. So this should be very generalizable to us because it's our patients. Now, the inclusion criteria was they were looking for index visits for patients greater than 18 years old with ICD codes related to hyperglycemia or diabetes or complications thereof, like DKA. And this included type 1 diabetics this time. So already it's very different than the driver study from animals I just showed you. Now, they were allowed to have other stuff wrong with them too. They could have like infections and ischemia and drug reactions and that kind of thing. And the only people they tossed out were people that had the wrong code put in, and people that were transferred from peripheral and community hospitals. Now, their outcomes were unplanned return ED visits. This time it was for 30 days. They also looked at specialist consultations in the ED, which we're not going to talk a whole lot about, and also patient disposition. They collected all sorts of data about the index visit and then did univariate, then multivariate regression analysis to see if they could determine any independent predictors of ED revisits for hyperglycemia. So trying to figure out the red flags we should look for when patients come in. So let's take a look at the results. There were 833 index visits, and 156 of them returned to the ED within 30 days. So just for a point of comparison, in the driver study at 7 days, it was 13%, and in this study at 7 days, it was 5.8%. It's a little bit lower. Now, of the initial visits, about half were given a non-emergent diagnosis of just labeled as, oh, this is diabetes. About half were discharged home. 1 actually died in Emerge, and 6 died while they were in hospital. Now, over the 30 days after getting admitted. And now 8.8% subsequently required admission, and 2 of those actually required ICU. Now, 75% of these repeat visits were for hyperglycemia, but 11% actually ended up having a more concerning primary diagnosis. There were 17 patients with things like MI, sepsis, pneumonia, UTI, that kind of thing. So after doing a regression analysis, they found 5 risk factors and 2 protective factors. And all of these reached a statistical significance better than 0.05, and in fact, the top 3 here were less than 0.01. And all the confidence intervals, the lower limit was above 1 for all of them. So not all of this is intuitive, though. Like, sure, previous visits, glucose greater than 20, that sort of makes sense for ED recidivism. But interestingly, younger patients seem to be at risk, too. On adjusted analysis, this was not driven by a higher proportion of type 1 diabetics. The authors theorized that maybe it's just because they were more likely to be non-compliant, because they're youths. Now, family physician thing up there is also kind of weird. Like, so much so, the authors went back and checked their homework, and yet the lower limit was, of the confidence interval was still above 1. In other diseases, like CHF and COPD, having a family doctor is actually shown to be protective. So this was their shot in the dark. They figured, well, maybe it's possible patients with poorer glycemic control are more likely to be proactive about having a regular GP, whereas people with better control might feel the need, less of a need to be rostered with a GP. But who's to say? It's really kind of a guess. Now here's the protective factors. And again, all were statistically significant with p-values less than 0.05. And again, it's not entirely intuitive. Like, why would tachycardia be protective? Maybe the individuals with the higher heart rates actually had some other disease process going on than just pure hyperglycemia, and they were less likely to return to the ED after that was treated, just for hyperglycemic control. So their conclusions were that family doctors are evil. No, that's not true. Obviously, he didn't say that. He didn't actually make all that many conclusions at all. It's a pretty interesting study, but Justin Yan was very careful not to sort of overstep or draw too many conclusions. It's a step in the right direction for future research and maybe a decision rule about who gets admitted versus discharged home. Now, I could hear some of you snickering. On the surface, it might seem like this study contradicts what I just said from the driver, the analyst study about the glucose threshold of 20. Now, firstly, remember, this study included type 1 diabetics, so they're not exactly the same study. And going forward, I'm personally going to be more careful with them. But there was also something else in the data that struck me. So 2/3 of the patients enrolled in the study for their index visit were there because of non-compliance or underdosing of insulin or their hypoglycemics. Now, these are potentially modifiable precipitants with some combination of counseling with educational interventions and close follow-up, just like the driver study. So I think these studies actually had more in common than not. Ryan Verdecki's analogy that I mentioned earlier to hypertension rings true. You shouldn't be treating numbers, you should be treating the patient. But just remember that badness still lurks in urgent care. So with the help of Mike Hale, we're going to do a quick little summary. No IV fluids unless they're osmotic diuresing.
Insulin is not, whatever it is. Homework is probably a good idea. Discharge removal alone is probably not advised.
Okay, excellent. Big hand for Mike Hale for being able to read at a 4th grade level. Thanks. From a practical perspective, and this was echoed by George Willis in a recent interview on MRAP, I think it's reasonable to at least get their glucose level down to a level that they can read it on their glucometer. Because if the blood sugar measures, which I'm not advocating to just like get rid of people right away, but just to make the point that if they can't read it, it's if it's just as high, you don't know if it's 33 or 80. And just so you know, the highest level of glucose I saw while looking through a whole bunch of case series was 150 millimoles a liter, which I've never seen. And there's probably people in this room that have, but I ain't never seen it. There was also one other really bad adverse outcome of higher discharge glucose levels that neither of those studies addressed, and that is the dreaded sugar high. This is like Adam Parks right before a night shift. Level of intensity. So I'm sure some of you guys remember Mike Thompson. He's one of our +1 EM alumni who now works in Victoria and BC. And he did a grand rounds on DKA in January 2014. So I'm not going to try and retread all that same ground here. He did a great job looking at the use of bicarb, insulin boluses, phosphate correction, and blood gases. And even if you weren't there or you don't have access to his presentation like I do, there's a bunch of great resources out there online to look up some of the literature summaries from recent years. But let's talk about some other potential pitfalls that we might be missing with DKA. So say you're in OBS and your med student starts reviewing with you by saying, I think this patient might be in DKA. They've already had some blood work and urine sent. So they got a blood glucose of 34, they've got a bicarb at 20, they're very mildly acidotic, 7.24. And the anion gap is 19, and there's no ketones in the urine. So their question to you stands, is this patient in DKA? And I totally admit, it's kind of hard to say with this incomplete information. I get that. And this might sound obvious to a lot of people in this room, but I have been handed over patients before with this story and told, I don't think it's DKA, the bicarb's not that low, and there's no ketones in the urine. Which brings us to our first pitfall, relying on urine ketones to rule out DKA. Now, trust me, I hate to put a slide with carboxyl groups on it, but I'm going to drop some biochem on your noggin here. There's 3 different ketone bodies that are produced and accumulate in DKA. There's acetoacetic acid, acetone, which is created by spontaneous decarboxylation of acetoacetic acid, and our old friend, beta-hydroxybutyrate. Now you might say, Rajiv, why are you bothering me with stuff that I haven't needed since the MCAT? Aren't all ketones the same? And the truth is, they're not. You see, urine dipsticks only pick up the acetoacetate because the nitroprusside in the sticks react with it, and to a lesser degree, acetone. But they don't react with beta-hydroxybutyrate, which can cause some diagnostic confusion. Because the predominant ketone body in DKA is beta-hydroxybutyrate. And that's even, it can be in a 10-to-1 ratio compared to acetoacetate. And that's even more pronounced when there's a lactic acidosis present. Now, for what it's worth, I think if you're entertaining the diagnosis of DKA, you need to get a proper VBG and serum beta-hydroxybutyrate and not be falsely reassured by a negative urine ketones if the serum hasn't been sent yet. And for what it's worth, just a little bit of trivia. Do you know what the 2 most common drugs are that can give you a false positive urine ketones? They're captopril and L-Dopa. Now this is another real case, not one that I saw, but one from the literature. It's a 40-year-old female with a febrile illness, nausea, and some shortness of breath. She tells you she hasn't been drinking, doing blow, anything like that. She's been taking less insulin recently because of her decreased PO intake, and she's got a medical history significant for type 1 diabetes and depression. She's on insulin, Invicana, and venlafaxine. And her vitals are as follows. She's got a temp at 38, she's tachycardic, tachypnic, and she's got some epigastric tenderness. So you're probably all thinking, okay, DKA talk, on insulin, this is going to be DKA. Now the point of care ends up being just 9. Now she's got an acidosis with a high anion gap, and she's got osmoles of 319, but even the serum measured glucose still comes back as 9.1. That said, the serum ketones, which you appropriately ordered, are positive this time. So you're trying to reconcile those 2 ideas. The rest of the blood work, the CBC, the LFTs, the lipase, all that stuff is normal. And so is the chest x-ray. So the question to you is this patient in DKA? Now, the emerged physicians in this case before treating her felt like this was not DKA because of the normal blood glucose. This patient was just treated with fluids, antibiotics, and bicarb and didn't improve. As a result, she was intubated and sent to ICU where she had a round of dialysis for acidosis, query sepsis, and until they eventually started an insulin infusion, the patient didn't improve. So this is an entity that's been getting a little bit more attention lately. You guys have probably heard about it. I think I heard some people whispering the diagnosis as I was giving the case. It's actually been described for decades now, although historically it was in a slightly different clinical context. I don't know why that's so funny, but okay, sure, I'll take it. Now, essentially it was described in insulin-dependent diabetics who took increasing insulin when they were sick, despite not taking glucose in. And so they progressed to ketogenesis without hyperglycemia. So this is the opposite of what people usually do when they're smart, where there's like, oh, I'm not eating as much, I should take less insulin. So it was either that kind of situation, or they were so late in a presentation of DKA that their gluconeogenesis was so profoundly impaired they couldn't like mount a rising level. So they had this like relative hypoglycemia looking normal. But more recently, this has been happening in the context of a newish class of drugs called SGLT2 inhibitors. Now you probably recognize some of the names even if you don't know how they worked. One of them was actually in the case I just gave you. You've probably seen it on a med list and thought to yourself, oh yeah, that's one of those new fancy diabetic drugs, and then just never thought to really look it up. They're available in Canada as Invokana, that's canagliflozin. There's Jardiance, which is empagliflozin, and something called Farxiga, which is dapagliflozin. So the common thread to help you cue into this is that they end in gliflozin. Again, that's helpful, guys. When you see gliflozin, think of euglycemic DKA. So SGLT2 inhibitors were approved for diabetes type 2 by the FDA only just a couple of years ago, and Health Canada followed suit shortly thereafter. They did also find there was a potential benefit for type 1 diabetics, improving average glycemia, they were getting less hypoglycemic episodes, and even had some weight loss. But shortly thereafter, people started getting sick, and the FDA noticed and actually put out a safety announcement about it. And the first case series of these published was by Peters et al. In 2015 in Diabetes Care. And I strongly suggest if you get a second, some like late bedtime reading, read this case series. It's pretty interesting, it's a great read, and it'll give you a flavor of the kinds of ways these patients can present. Now, the way this medication works, I'm pretty sure this is a tubule in the kidney. The way this medication works is by inhibiting the sodium glucose transporter, so SGLT, in the kidney. So you functionally start dumping a ton of glucose into your urine. So although your body is still unable to use the serum glucose, like a typical DKA progressing to ketosis, you don't actually get hyperglycemic. Instead, you progress towards normal glucose levels because of increased glucose excretion. And what's also really important for you guys to recognize is that this phenomenon is described in type 2 diabetics as well, which is not typically a population we associate with DKA. Now, why it happens in type 2 diabetics is not really well understood. So you can just like make up a mechanism if you want to. I'm going to call it cytokines. It's always cytokines. It's my answer for everything in the exam. The good news for you guys is that luckily there's not really anything that you have to do too much different for either workup or management compared to our more run-of-the-mill DKAs. It's just that because of the relative hypoglycemia, you need to start your dextrose infusion sooner. The real bugaboo for us is just simply being aware of the diagnosis and not taking pushback from medicine when they say, oh, no, this can't be DKA, the glucose is too low. Just tell them, yes, it can, and then slide that little case series towards them. So I'd be remiss if I didn't make a totally shameless plug here. If you're super lazy and you don't want to read that case series I told you about, check out an episode of a podcast that I sometimes host. It's called Emergency Cases, Best Case Ever. It's a series under EM cases. And it's an interview with Dr. Walter Himmel, where he runs through the first time he was stumped by euglycemic DKA. And I didn't host this episode, Anton Hellman did. But I love it anyway, because if it can trick Walter Himmel, who works 30 shifts a month for like 40 years, it can totally trick me, and it can probably trick some of you. So this is a third case, and another one that also really actually happened. There was a 23-year-old female on her third pregnancy, in her third trimester, that was asked to be assessed by EMS in the emerge because they had concerns about taking her upstairs to the OB floor because she looked so unwell. Her chief complaint was weakness and vomiting for 3 days, and she'd never had a previous diagnosis of diabetes or gestational diabetes. Temperature was 37.3, she was tachycardic, she was tachypnic, but had a normal blood pressure. And she did have dry mucous membranes, but the rest of her exam was pretty much unremarkable. You might be tempted to say, with this blood work, lights are normal, mild white count, acidosis, but the serum glucose only being 11. You might be tempted to look at the urine and say, well, those ketones, that just might be some starvation ketosis because she's been vomiting, she looks kind of dry. Well, this patient was admitted with a diagnosis of pyelonephritis and hyperglycemia. And although insulin was eventually started, and it was just subcutaneously, 10 hours after admission, after difficulty obtaining a continuous fetal heart tracing, they realized that the ultrasound was going to confirm an intrauterine fetal demise. So was this patient in DKA? The answer is yes. And why did this happen? Why did this diagnosis get missed? Essentially, it was delayed recognition of the clinical manifestations of DKA in pregnancy. And had a timely diagnosis been made, and appropriate fluid and insulin infusion started, this adverse outcome could have been avoided, just simply by correction of the maternal metabolic disturbance, and then hopefully preventing that fetal death. Now, we know ketoacidosis is associated with risks for mom, but what you might not know is fetal mortality rates have recently been found to be as high as 9% in maternal DKA in pregnancy. Now, previous studies said that number was as high as like 30 to 90%, but there was a better one recently, so probably closer to 10, but it's still a really high number, right? Now, the fetus can become acidotic from keto acids that cross the placenta, and that subsequently decreases uterine blood flow, and it can decrease tissue perfusion of the baby. And aside from this, maternal hyperglycemia in and of itself causes fetal hyperglycemia, and then osmotic diuresis in the baby. So I hate to do a basic review, but there's some physiologic changes associated with pregnancy that is helpful to review. First, normal pregnancy is associated with insulin resistance, similar to that found in type 2 diabetes, with accelerated lipolysis and ketogenesis. And several of the hormones in pregnancy, like human placental lactogen and cortisol, progesterone, all of these impair the action of insulin in mom, and then contribute to this diabetogenic state. The concentration of serum ketones has been estimated to be 2 to 4 times higher than the non-pregnant state. And finally, the acid-base status of pregnancy is a compensated alkalosis with a bicarbonate that usually sits a little bit low. All of these lead to a recipe for increased rates of DKA. And the really scary thing is 30% of women with previously undiagnosed diabetes presented with DKA as their first presentation. So here's the tricky part. The degree of hyperglycemia with DKA in pregnancy may be blunted because of decreased glucose production or because of increased glucose utilization, because both the fetus and placenta utilize large quantities of glucose that result in lower fasting levels for mom. So Cullen et al. Reported their experience with DKA complicating pregnancy over 10 years, and they found that the mean glucose concentration for DKA was only 18, and the range was as low as 7.2 to as high as 37.8. Now, that higher level is kind of like what we're used to seeing for DKA, but to think like, 7.2 could be DKA is not something that we heuristically usually think about. And in 36% of cases, the glucose was less than 11. So there's rare cases of true euglycemic DKA in pregnancy, although most cases had a blood glucose level greater than 7. So I just want you to be aware. It's hopefully not something we're going to see a whole lot, but DKA can be the first presentation of diabetes in pregnancy. The glucose levels can be lower than you expect, so don't get falsely reassured by that. And we should be aiming for lower blood glucose levels than we do with our standard DKA. And we're going to talk about that a little bit more in like just a second. So I just want to summarize that second part. Hale, you get a pass this time. You don't got to do anything. So negative urine ketones can be falsely reassuring, so I don't want people in this department to be saying that ever again. If you see someone that's on a gliflozin and is sick in any way, any sort of weird symptoms, just think about the diagnosis of euglycemic DKA. And remember that in pregnancy, DKA can both present with a lower level of sugar, and they need to be treated to a lower level of sugar as well. So let's talk about how we manage DKA here at TOH. Now, I feel pretty lucky I get to present this material to you guys because it's a lot of hard work from some behind-the-scenes people from a lot of different services, and I kind of think that's what Grain Rounds is all about. It's like bringing this kind of stuff to the forefront of our minds. And I have thank yous at the end, but I just want to do a quick shout out to Philomena D'Souza, one of the endocrinology nurses, and Carrie Poulin for helping me put together this last part of the talk. So this is a pre-printed order set that I'm pretty sure everyone in this room should be super familiar with. This is our DKA protocol. And it was developed by a multidisciplinary working group with representation from internal medicine, emerge, nursing, and pharmacy to minimize the practice variation and ensure we all stick to best practice guideline care for patients with DKA. Now, you might be wondering, since we started using this, has it actually made any difference for our DKA patients? Well, the answer is yes. So some of the people in internal medicine, residents and staff, all got together and presented this at the TOH Patient Safety Conference last year. So essentially, it was a pre- and post-implementation retrospective observational case series. And it should be mentioned that the only real difference was the PPO. So some of the, like the insulin PPO and the increased diabetic nurse specialists, other stuff that might affect DKA care, that was already in place for the pre-protocol group as well. So there's 55 patients in each group. So it was like the pre-group was the academic year 2013-14. And the post group was the academic year 2 years later after the protocol was put in place. They looked at a number of, I think, appropriate clinical outcomes like use of labs, use of fluids, how long it took the anion gap to close, and iatrogenic complications. And they also looked at, like, more globally at how many people were actually using the protocol and how it contributed to other system outcomes. So all in all, it demonstrated success. By June 2016, 88% of these patients were being managed with the protocol. You can see that there's improvements in the appropriate labs being done, getting IV fluids as necessary, insulin being given until the gap closed, and the time to anion gap closure was 4 hours shorter. And these are all statistically significant numbers. There was also less of the iatrogenic complications of hypoglycemia and hypokalemia, and the length of stay was about a day and a half shorter for the group that was getting treated with the protocol. Interestingly, Ed Kwok actually sent out a survey just earlier last year, and for the people that answered, 74% of physicians felt that the protocol improved care, which means that like 1 in 4 people were not really buying into it all that much, which kind of surprised me. I kind of thought the protocol was like something that we would all be, really head over heels into, sort of like the sepsis protocol. So the summary for the DKA TOH is that in general, I would call this a win for patients. It's kind of a ridiculous picture right now. I don't really like it. This is me when I was 5 years old. But obviously not. But the DKA protocol hasn't all been roses. There's been some proposed changes when some flaws were noticed in care over the past couple of years. So the first one, you guys just like raise your hands if this has happened to you, having the insulin infusion rate reduced before the anion gap is closed. So sometimes what will happen is the glucose dips below 12, and because of the protocol, it says that we have to back off the insulin, even if the patient is still acidotic with a high anion gap. So the plan is to rework this to add a minimum infusion rate. Basically, the nurse has to call the MRP, whether that's you or medicine, if the rate is going to go below 1 unit per hour, which is not the way it is now. It also added a clause that the nurse has to call the MRP if the glucose is in the lower range, but the anion gap and acidosis are still present. So hopefully, this should prevent premature discontinuation of insulin infusions that's been happening. The second situation is euglycemic DKA, which we just talked about. Now, they're still in the process of trying to determine if a full other form is necessary or if changes could happen to this one to cover this clinical situation. Now, my opinion, based on the prepping for this talk, is that the new proposed DKA protocol that I just talked about should be adequate so long as we accept those proposed changes for the persistent anion gap and emphasize that dextrose infusion has to be continued with high or normal euglycemia. And finally, as I pointed out, we need to consider the fetal effects of maternal hyperglycemia. So unfortunately, there's really no evidence about what this target should be. I did a pretty thorough lit search, and the team working on this did too. But expert consensus has deemed a lower target to be reasonable so that you balance those risks of hypoglycemia versus negative fetal outcomes in the context of hyperglycemia. So this is more critical if the patient is in first trimester during organogenesis, which could totally be our responsibility, or if birth is really imminent, which we just cross our fingers is not our responsibility. The new proposed target should be safe for both of these cases. So this is, I'm not sure if it projects very well, but this is what the new protocol is going to look like. Just from top to bottom, they are showing that the physician has to adjust targets for pregnancy to be lower. So instead of 12 to 14, it's going to be closer to 5 to 8 single digits. The insulin infusion rate is not to be reduced to less than 1 without talking to a doc first. And similarly, you have to call the MRP for the IV fluids and insulin orders if the glucose is low, but the pH and anion gap are still high. So I just want to quickly cover the last point for today is just resources for newly diagnosed diabetics. I know you're all busy people when we're on shift, but we need to make sure that we're doing good by our patients. There's some studies recently that found that in all ED visits for 1 month, 3% of ED visits that had hyperglycemia without a diagnosis of diabetes were not referred and that were at risk for undiagnosed diabetes and prediabetes. So in a similar study, 1 out of 45 patients, that's 2.2%, with elevated blood glucose were even informed of their elevated level and referred for appropriate follow-up. So the thinking of these two studies, and I think appropriate conclusions, are failing to inform and provide a referral minimizes patients' abilities to make relevant lifestyle changes to help prevent or delay progression of diabetes. So if nothing else, the theme of today was to ensure follow-up and provide some education. So here are some ways that you can do exactly that. So even if the patient doesn't have a GP or specialist following them, you can refer them to the diabetes clinic. Just be aware that the wait time is pretty long. It's like a year. So they're saying that consider referring mainly complex cases or patients that have new diagnosis of type 1 diabetes. And don't forget, there's diabetic nurse specialists that work during the weekday hours, Monday, Friday, 8 to 4, that can provide services for new diagnosis or urgent education needs. So they can provide just-in-time teaching, which means issues with like insulin pump, insulin dosing, major changes in treatment, type 1 patients with DKA, that kind of thing. And they can also help with discharge planning and determining the best follow-up destination. And don't forget, there's always an endocrinology physician consult service, 24/7. I know no one likes to page endo. No one even knows what the abbreviation is on OASIS. But they're always there 24/7 if we have really urgent questions. And patients who require basic education can be referred to a community diabetes education program. So this program can help patients find the GP, and they will even see the patient if there is none. And if the patient's management is complex, just remember, send them to the diabetes clinic instead. Some examples they gave me were that people with lots of comorbidities or active cancer, high-dose steroids, that kind of stuff. Those are the people that we should be referring. So that's it. It's not Reboa, it's not transesophageal echo, but it's something that we see a lot. Thanks for sticking with me. I want to thank a lot of people. Eric, first of all, for being my supervisor. Unfortunately, he couldn't be here today. Justin Yan and Mike Thompson for providing me lots of invaluable resources. Philomena and Carrie for letting me sort of peek behind the curtain of how the DKA protocol works. Matt Lipinski, my buddy, for his fatherly advice and just the sensible attitude and feedback that I don't always have. And finally, because I don't have a wife and kids, I want to thank my calculator, because you wouldn't believe the number of times I had to divide by 18 to create this presentation to convert US units to international units. So, of course, I'm open to any questions.